Assalamu alaikum wa rahmatullah. Good evening, everyone. Thanks for joining us for the third Young Leader Forum for the year 2022. The theme today will be around the endocrine oncology, and we extend our thanks to Serbia for their unrestricted support for this activity. Before we start, we have 3 lectures today. However, there are housekeeping announcements. This webinar is live streamed in EDS YouTube channel, and also it will be available as on-demand webinar on the website of the Endocrine Diabetes Emirates Society website. So for those who want to view the lectures again, they can access that. During the presentation, please place your questions in the Q&A section, and we will address them after the 3rd session. If you need any support, you can WhatsApp on the displayed number, and CME hours have been applied for this activity, and you will be contacted through emails once we get the approval. So to start with, our first lecture will be about diabetes and oncology, and our speaker is Dr. Asma Al-Jabari. Dr. Asma is a consultant endocrinologist at the Department of Medicine in Tawam Hospital, and she also is adjunct assistant professor in the College of Medicine and Health Sciences, United Arab Emirates University. She received Outstanding Abstract Award, the Travel Award in Endo 2020, and her field of interest in endocrinology are osteoporosis, bone metabolism, obesity, and lipid metabolism disorders. So, Dr. Asma, thanks for being with us, and the screen is yours. You could share your slides, Dr. Asma.
Thank you, Dr. Araya, for the kind introduction. I'm trying to share my slides. Can you allow me, please, Cheryl, to share my slides? Thank you again, Dr. Araya, for the kind introduction, and good evening, everyone. My topic today is going to be about diabetes and oncology, and it's going to be a literature review. I don't have anything to disclose, and my objectives for tonight is going to be talking about the link between diabetes and cancer, and basically I'm going to talk about the epidemiological link and diabetic pharmacology pharmacotherapy link with cancer. Then I'll move to talk about anti-cancer therapy and hyperglycemia, and I'll pass through talking about some challenges we're facing in management of diabetes in patients with cancer. So the talk about the link between diabetes and cancer started a long time ago, more than 100 years back, when Maynard published his study in 1910. That was the title of the study was a statistical study in cancer death rates. And he stated in the article that both diseases have very much the same age distribution. They stand almost alone as being on the increase, while other causes of death show declining rates. The etiology of both diseases is obscure, both being disease of old age. If there were a common factor in the position of the dual increase, a correlation between these diseases might be discovered. Can you imagine that was more than 100 years back? So after that, there have been many studies published studying the link between diabetes and the cancer. And these studies showed around between 8 to 18% of cancer patients have diabetes, and 60% of the newly diagnosed cancer patients aged 65 and above, and about 25% of those patients have diabetes. 1% of the new onset diabetes patient aged 50 and above had pancreatic cancer. And this is based on many of the meta-analysis. And here I'm showing a meta-analysis by bias analysis for a major confounding factor of 151 cohorts studying millions of patients all over the globe. And these studies showed that there is increased risk of cancer at all sites in both males and females with diabetes. And here, this is showing the increased risk by 6 stratified analysis. And again, it's showing increased incidence of cancer at all sites and increased the mortality at all sites when the patient is having diabetes. This is another study. It is a population-based case control using SIR, looking at the link between diabetes and hepatocellular carcinoma. And the study showed that there is a significant correlation when the patient is having diabetes, and it is a risk factor for hepatocellular carcinoma. Here I'm showing another epidemiological study. It is a meta-analysis of breast cancer patients, showing that the patients with diabetes, they're having a higher risk, and the relative risk of cancer was significant with 1.27 of all the studies in that meta-analysis. Kristen Erickson published a very nice paper studying the breast cancer in the diabetes patients, was published in 2011, and that US breast cancer cohort were studying the baseline hemoglobin A1C and mortality of breast cancer survivors. And as you can see from this graph, that the higher hemoglobin A1C, the higher mortality rate in those patients. In the same study, Erickson showed that the overall survival after breast cancer diagnosis in patients with hyperglycemia is lower when the patient is having higher hemoglobin A1C. And if you're looking here at this is Kaplan-Meier curve, that the overall survival for patients, the follow-up was about 15 years, and the patient was living longer when they're having a lower hemoglobin A1C. And she's also showing that the breast cancer event-free was longer when the patient is having lower hemoglobin A1C. So another meta-analysis was studying the pancreatic cancer and diabetes, and it was found that the diabetes is an independent relative risk of pancreatic cancer in that meta-analysis with 1.94. And that relative risk of pancreatic cancer increased with higher insulin and C-peptide level. And they concluded that the diabetes could be an early sign of pancreatic cancer in such patients. And here it's also showing that this graph is showing that the pancreatic risk was higher when the patient was having high insulin level and the C-peptide. So now I talked about the epidemiological link between diabetes and cancer. So we need to understand what was the mechanism behind increasing this risk. And there are so many hypotheses, but I'll talk about the main mechanism we could address in this lecture. So most of the patients who we're studying having cancer are type 2 diabetic patients. And diabetic, most likely they're having also obesity, and that causing insulin resistance and causing hyperinsulinemia. Hyperinsulinemia would affect the beta cells and lead to hyperglycemia eventually. Hyperglycemia would affect the tumor cell growth. The insulin resistant also will affect the liver and will decrease the 6-hormone binding globulin, which would increase the IGF-1. And at the same time, because most of those patients, they're having also increased the adipose tissue mass, they're having a higher macrophages and ECM proteins, they would increase the production of estrogen. With the decrease of SMBG and higher level of estrogen, the bioavailable estrogen level is going to be high, and that would also stimulate the growth of the tumor cells. The macrophages, the higher quantity of macrophages in the adipose tissue will increase also the cytokines levels, and at the same time also will increase the fatty acids level and leptins, and both will also stimulate the tumor cell growth. Talking about the mechanism and the link between diabetes and cancer, we should not forget to talk about the microbiome. So we know that millions of organisms are living in our system, and they're living in harmony and functioning very well to maintain the homeostasis in the human body. When the patient is having diabetes, the hyperglycemia is disturbing this harmony and the functionality of the microorganism. And that will lead to increase the cytokines levels and will increase the production of factors released by the microbiota, and both would affect the tumor growth on the long run. So I addressed the epidemiological link between diabetes and cancer, and I talked about the presumed mechanism of cancer and diabetes in cancer and diabetic patients. So the other side of that, I need to talk also about the diabetic pharmacotherapy and the link of cancer. We're having a couple of classes of anti-diabetic agents, and each of them has a different mechanism of action. And those medications were studied in a preclinical study, and showed that there is a preclinical evidence of effect on cancer. And also those medications, after being in practice, many studies have been done and showed that there is clinical evidence of potential effect on cancer. So we just labeled them as the good, the bad, and not so ugly medications. And I'll talk about one by one. So we heard a lot about the metformin and cancer effect, and reviewing the literature, there were more than 300 metformin studies in cancer registered at NIH. And the outcome measures, which were measured in these studies, either tumor signaling, tumor proliferations, cancer progression, and patient survival. And most of these studies showed that the metformin decreases the risk of certain cancer and improve the response to chemotherapy. And metformin may reduce the tumor growth by direct and indirect mechanism. In this slide, we're trying to highlight the effect of metformin. So as I mentioned, there is an indirect and there is a direct way to affect the tumor cells. So indirect way, that by the effect on the liver, the energetic stress will be decreased by increasing the AMP kinase. Increasing the AMP kinase would decrease the gluconeogenesis, leading to decreased glucose, and that will eventually decrease the insulin level, and will decrease the insulin, which would interact on the receptors on the tumor cells. The main effect, and what most of the researchers think, that the direct effect of the metformin is going to be on the tumor cells itself. By increasing the AMP, the mTOR would decrease, and mTOR is a very important point in tumor signaling and the proliferation. By decreasing the mTOR, that would decrease the energy consumption and lead to cytostatic effect on the cells. And those are the mechanism what most of the studies are talking about. This is a meta-analysis review of metformin and the cancer risk in diabetic patients, and most of the studies done showed that there is a link in terms that metformin decreases the risk of cancer in such patients. And this is also a graph showing that the patients, the metformin used in stage 4 lung cancer had a better survival rate when they were started on metformin. So the next class of medication is TZD, and as endocrinologist, I've been hearing long time since I was a resident about the risk of cancer with Gliclazide. And that was coming to the practice after a proactive study, which is a prospective multi-center randomized control study published in early 2010 or 11, it showed that there is an incidence of malignancy. The incidence of malignancy were similar on both groups, the TZD patients and the control. However, they found that fewer breast cancer cases with pioglitazone, but more bladder cases with pioglitazone. So after that, there were a couple of studies done trying to understand the link, or trying to clarify if there is a link between pioglitazone and the bladder cancer. There was a population-based cohort study studying the bladder cancer risk in patients treated with pioglitazone and diabetic patients, published in BMG in 2016. And that study really didn't clarify that much the doubt, and they concluded that the risk is duration dependent, and the shorter the duration, the less risk; the longer the duration is the higher risk of developing the cancer. Now I'm going to talk about incretin-based therapies and cancer. As someone who's using incretin much in the practice, doing the obesity clinic, I'm almost every week receiving patients coming with news from media talking about the risk of cancer and incretin, especially GLP-1 agonist. The link between GLP-1 agonist and the cancer was only coming from preclinical data, and that was on rodent C cells. So the studies in preclinical studies showed that there is an increase in number of C cells, and there was a link between MTC cell with the prolonged treatment with incretin therapy, especially GLP-1 agonist. And the GLP-1 agonist is stimulating the increase in, leading to increase in the calcitonin level in rodents. And rats, which were treated with a weekly exenatide for 2 weeks, had increased the incidence of thyroid C cell neoplasm, either adenoma or carcinoma, in both males and females at all doses. But we don't have any human or clinical studies done in a human and prove that the link. So the human relevance of finding is unknown yet. Now I'm going to talk about the SGL2 inhibitor and cancer. And SGL2 inhibitor for us as endocrinologists really made a great change in the management of diabetic patients because of the improvement in hemoglobin A1C and glycemic control with such medication. Trying to find if there is any link between SGL2 inhibitor and cancer, I found that there was an interim clinical data in May 2011 which showed that the overall incidence of malignancy or unspecified tumor was balanced in patients treated with SGL2 comparing to the other medication. However, there was imbalance in some tumor types and was noticed, and mainly they found that the dapagliflozin increased the risk of bladder cancer. After that, in the same study, they went back and studied all the cases of bladder cancer, and they found that most of the patients who had a bladder cancer, they were having hematuria at the time of enrollment in the study or soon after enrollment. So they think that the bladder cancer and dapagliflozin studies were most likely pre-existent and has nothing to do with the medication itself. I also tried to look if there is any other data looking at the SGL2 inhibitor and risk malignancy, and I found that there is a meta-analysis of randomized controlled trial studied the SGL2 inhibitor and risk of malignancy. And in this meta-analysis, they concluded that ertugliflozin and dapagliflozin seem to increase the malignancy risk in type 2 diabetic patients, and empagliflozin may decrease the malignancy risk. And when they compared the SGL2 inhibitor with the other active hypoglycemic agent, they found that there is an increase of overall risk, primarily in the digestive system compared to a placebo. So we left here with, again, unclear conclusion. The relationship between SGL2 inhibitor and malignancy in type 2 diabetic patient is still unclear for us. Finally, I'm talking about, in terms of the diabetic medication pharmacotherapy, about insulin analog and cancers. There was a concern at the end of 2009, 2010 about the risk of cancer in patients on exogenous insulin, and especially Glargine. And a couple of studies actually were done. Most of them were epidemiological data, not a randomized control trial. And that confusion was cleared in 2012 when the Origin trial came out. And the original trial was studying the effect of a Glargine insulin and the risk of cardiovascular disease. And one of the first co-primary outcomes in this study was any type of cancer or death from cancer. And this study clearly showed that the hazard ratio for any cancer was 1, and the death from the cancer was 0.94. So this study really cleared the confusion and showed that there is no link so far between the insulin and the cancer. So in summary, regarding of the insulin, that epidemiological studies have conflicting results. Recent prospective studies report no increase in the risk of cancer, and in vitro studies should be interpreted with a caution as they are a questionable physiological relevance. There is no definitive data suggesting an increase of cancer risk in patients on exogenous insulin compared to patients who was having their normal human insulin. And this is very important because we're having lots of patients treated with insulin, which is a life-saving medication. Now I'm going to talk about the link between anti-cancer therapy. So we're flipping the coin. It's not the anti-cancer therapy and hyperglycemia. So we're having different classes of medication used in treatment as a chemotherapy. It's either targeted agents or immunotherapy, hormonal therapy, steroids, and diazoxide, and other couple of medications. So we can divide them into two groups: a group of medication which decrease the insulin, and the group of medication which increase the insulin resistance or hyperglycemia. For example, if we're looking at the immunotherapy, immune checkpoint inhibitor, they're decreasing the insulin secretion. Hormonal therapy, if we're looking at the somatostatin analogs, it suppress the insulin secretion. But if we're looking at anti-androgen therapy, it's also causing the increase in insulin resistance. Diazoxide decrease the inhibit insulin secretion, and the other targeted therapy, it would increase the insulin resistant and causing the hyperglycemia. So our colleague, the oncologists, are facing also a couple of challenges when they're treating their diabetic patients with cancers, because most of these patients, if they're an elderly and they're having established disease, they might have a comorbidities or a complication of diabetes itself. For example, we know that kidney impairment is one of the complications of diabetes, and if the patient needs any chemotherapy, which is renally excreted or metabolized by the liver and excreted by the kidney, like cisplatin, would be really an issue in this condition. And the oncologist should pay attention that he might need to decrease the dose or change the chemotherapy for that patient. Other thing that also the cardiovascular disease in diabetic patient is an issue because some of the chemotherapies are cardiotoxic and might cause the vascular spasm, might cause myocardial necrosis, might cause also arrhythmia, like HER2 inhibitor chemotherapy used in a breast cancer patient. It's a cardiotoxic. So such patients with a cardiovascular disease would be really challenging patients for the oncologist when they're starting them in chemotherapy. Other complications of diabetes is a neuropathy. Diabetic patients with a neuropathy and having cancer is also might face an issue with the medication, because some of the medication might cause the peripheral neuropathy. For example, oxaliplatin, which is a very good type of chemotherapy used in stage 3 colon cancer patient, decrease the risk of recurrence and increase the survival rate. One of the medication which can cause neuropathy. So if the patient is already to start with is having severe neuropathy, would be an issue to start him in a medication which might worsen his neuropathy further. Now, after looking at the epidemiological risk link between diabetes and cancer and looking at the risk between anti-cancer therapy and hyperglycemia, it's so clear that we need to screen patients for diabetes, even those who is not known to have diabetes as a baseline when they started to be treated for the cancer. And this is important because up to 1/3 of the patients with diabetes are undiagnosed, and the screening for the diabetes is important before embarking any patients on systemic therapy, and especially for a very high risk factor patients with high BMI, physical inactivity, patient who's going to be treated with targeted agent known to increase, cause hyperglycemia, or steroids associated hyperglycemia. So for us as endocrinologists, we're also facing challenges treating those patients, diabetic patients with cancer. And this is because of the comorbidities due to either the general condition of cancer patients or the treatment side effects. For example, altered appetite and low calorie intake will put the patients at a very high risk of either hyperglycemia due to stress and might put them at risk of DKA, or severe hypoglycemia because of the decrease of the oral intake and being on a treatment, for example, the anti-diabetic agents. It's also challenging because those patients might be started on treatment, and that would affect their renal, hepatic, cardiac function, and the diabetic medication would be either contraindicated in this case due to increased risk, for example, for metformin, lactic acidosis, or bioglitazone, for example, causing the edema, worsening pulmonary edema or retention. The steroids is also an issue, and when we're covering in patients, we're receiving many consults from our colleague, the oncologist, because of the steroid-induced hyperglycemia, which sometimes is really very dramatic and would be very difficult to control without having the patients either on insulin or continuous insulin. So from that, we understand that it's very important to treat the patients appropriately when they're having cancer, and trying to control their glycemic control as much as we can. Here, the list of all the diabetic medications available with the mechanisms of action. I cannot give an advice for one specific advice because there is no one size fits all. When we're treating diabetic patients with cancer, we should put in consideration every information around the patients. What is his comorbidities? What is going to be his anti-cancer therapy? What is expected, the side effect expected from the chemotherapy? What is the underlying disease as a complication of diabetes? But in general, the advice is that we need to close monitoring the blood glucose during the cancer treatment. Patients on oral anti-diabetic agent may require short course of insulin therapy during the treatment. And patients using insulin, they might need a further dose adjustment. We need also to be vigilant because those patients, especially in advanced cancer cases or when they're started in very strong chemotherapy, they might have severe GI symptoms and with a low appetite. So we should be really watching for the risk of hypoglycemia, and that will warrant less aggressive measures in their treatment. Here I'm showing, talking about mainly the management of targeted therapy-induced hyperglycemia. So patient who is having hyperglycemia, who is not known to have diabetes, but developed hyperglycemia secondary to cancer therapy. And the I found this recommendation published at the end of 2021 in Cancer's journal. They divided the severity of hyperglycemia in 4 grades. Grade 1, when the patient is having a glucose upper normal up to 160. Grade 2, when they're having between 160 to 250. Then grade 3, between 250 to 500, and 500 and above, grade 4. So the general recommendation for grade 1 and 2 and 3, lifestyle modification, metformin, if the general condition of the patient is allowing that, no risk of lactic acidosis, and the adjustment of the chemotherapy based on the level. For example, if the patient is having grade 1, no need to stop the medication. Patients can continue the anti-cancer therapy, diet and lifestyle modification. If the patients remain to have a high blood glucose, then we'll consider metformin. Patients at grade 2, if the patient is symptomatic, advisable to hold the treatment, the anti-cancer treatment, for 48 to 72 hours until improvement. Diet and lifestyle modification, start metformin. If the patient remains to have blood sugar more than 200 after 2 weeks, to add another hypoglycemic agent. And if the patient continues to have poor blood glucose, to add insulin. If the patient is having grade 3, between 250 to 500, chemotherapy should be stopped until the patient reached blood glucose less than 250. Metformin should be started at that time with hydration, metformin, other medication, oral medication, if general conditions allowing that. And if the patients continue to have above 250, the insulin should be started. If the patient is having the blood glucose more than 500, the chemotherapy should be stopped until the blood glucose is less than 250. Patient should be, in this case, started on insulin directly and not wait till the metformin effect.
So before I end, Dr. Asma.
Before I end, the diabetes and cancer outcomes showing clearly that the diabetes may negatively influence the cancer prognosis because of other associated comorbidities linked with diabetes, and because the diabetes increasing the risk of non-cancer related causes of death, and because it stimulates the cancer growth and progression. And as all the studies showing that the higher mortality and recurrence rate after diagnosis and treatment of underlying cancer. So I'm here coming to the end of my presentation, and take-home messages. Cancers are a major complication of diabetes and obesity. Surveillance should be part of the clinical evaluation of these patients. We need to define cancer to be screened on those patients. So should we screen breast cancer earlier on those patients? Should we screen for pancreatic cancer earlier? We don't have clear recommendation, but since we're having an evidence that it increased the risk, maybe we can discuss it with the patients and see if we can screen it earlier. Association of certain antidiabetic agents and cancer seems small and inconclusive. Managing patients with diabetes and cancer can be a challenge. Options of lowering the glucose in diabetes are expanding rapidly. Foundation therapy remains lifestyle modification and metformin. Beyond metformin, several options are available, each with advantage and disadvantage. And it's important to weigh the risk and benefits of each agent to design a treatment regimen individualized for each patient. By this, I'm coming to the end of my presentation, and these are the list of my references, and the mic goes back to Dr. Araya.
Thank you so much, Dr. Asma. Excellent review. So we will move to the second talk, and the second talk will be, the title of the second talk is Be Smart with the Glands, and our presenter is Dr. Reem Al-Arjan. Dr. Reem is a consultant internist and endocrinologist at King Fahd Hospital of the university. And also she is currently the head of the endocrine section and diabetes center at King Fahd Hospital of the university. And she is a professor at Imam Abdurrahman bin Faisal University. Thank you, Dr. Reem, for being with us. And the screen is yours. You can share your presentation.
Good evening, everyone. Thanks, Dr. Raya, for the nice introduction, and thanks for the organizers for the invitation to be part of this webinar. So I'll be presenting a case that's entitled Be Smart with the Glands. So starting with the case presentation, we're having a 53-year-old female who is known case of type 2 diabetes mellitus. She presented initially to her general practitioner with history of headache and vertigo, for which MRI brain was done and showed pituitary macroadenoma. Prolactin level was done by her GB and revealed high prolactin level of 399 with upper limit of 26.7. She was started again by her physician on cabergoline at a dose of 0.25 milligram BO twice per week. And after that, she was referred to our endocrine clinic for evaluation. So we could ask the attendees now at this stage, what do you think the best next step in management at this stage upon the brief introduction that was given to you of the patient? Would you think that prolactin level is matching the size of adenoma, so cabergoline should be continued? Would you do prolactin level with dilution? Would you do pituitary MRI, or you need to obtain further history? Please share your votes. You have 10 seconds to share your votes. So we're seeing at least 30% they want to do a pituitary MRI, another 30% they want to obtain further history, and we have like 17% they want to do prolactin with dilution, another 20% they think that the size of adenoma is matching the level of prolactin, so cabergoline should be continued. So speaking about the causes of hyperprolactinemia, we always have to keep in our mind that prolactin or high prolactin level is not always a prolactinoma. We have many causes of hyperprolactinemia that start with simple physiologic causes, like, for example, sleep, physical exertion, pregnancy and postpartum, nursing, and stress. And along with that, we have the other pathologic causes that include pituitary hypothalamic disorders, including prolactinoma, acromegaly, infiltrative disorders, or sometimes even stock compression could cause a high prolactin level. Other disorders that could cause hyperprolactinemia include primary hypothyroidism, seizures, polycystic ovary syndrome, renal failure, or liver cirrhosis. And we have, of course, the medication, where we have a wide variety of medication that could cause hyperprolactinemia, including opiates, metoclopramide, antipsychotic medications. So we have always to keep that in our mind. And we have also know that serum prolactin usually parallel the tumor size. So, and it was shown in multiple studies. So, for example, in this study of 223 patients, where non-functioning pituitary adenoma was in 175 patients and prolactinoma was in 48 patients, there was really good correlation between serum prolactin level and prolactinomas. However, the correlation was weak in patients with non-functioning pituitary adenoma. But is there a cutoff where we could say that those patients is most probably prolactinoma rather than other tumors? So there were several studies that looked into this. For example, this study of 226 patients with non-functioning pituitary adenomas with a median age of 55 years. Majority of them, they were gonadotroph adenoma, and it has some other types of non-functioning pituitary adenomas, including null cell blue hormonal and silent ACTH adenoma. It was found that at least in 98% of non-functioning pituitary adenoma, prolactin level was less than 2,000 mU per liter, and that will be consistent to a nanogram of less than 94 nanogram per deciliter. So in general, less than 100 is mostly goes with non-functioning pituitary adenoma rather than prolactinoma. So we need to keep this information in our mind whenever we evaluate such patients. So in general, prolactin level between upper limit of normal and 100 microgram per liter may be due to either medications, estrogen, or functional or idiopathic causes, but it can be also caused by small adenomas like microprolactinomas. Most patients who have a prolactin level more than 150, at least 5 times more than upper limit of normal, they will have a prolactinoma. And usually macro adenomas are typically associated with levels more than 250, and in some cases more than 1,000. However, these values are not absolute. Some prolactinomas can present with variable elevations in prolactin, and there may be dissociation between tumor mass and hormonal secretion. So we always have to be cautious whenever we interpret a moderate elevation of a prolactin to make sure it's not a stalk effect that's caused by compression of a prolactinoma on the stalk itself. And another thing to be kept in mind that usually as recommended by Endocrine Society, prolactin level more than 250 usually indicates the presence of prolactinoma. However, some medications like risperidone and metoclopramide, it may cause prolactin elevation above 200, even in patients without adenoma. So going back to the history of this patient, at endocrine evaluation, her history was reviewed. She was a 53-year-old lady with a background history of type 2 diabetes for 13 years. It was complicated by nephropathy and neuropathy in the form of gastroparesis, and she was maintained on antidiabetic medications and prokinetics in the form of domperidone. She was also known to have obstructive sleep apnea on CPAP. She would also have depression on antidepressant medication. She had the recent history of thyroid nodule that was evaluated by ENT and showed benign cytology. And she was already postmenopausal for 6 years and it was preceded by regular periods and some perimenopausal hot flashes. Her review of her symptoms were remarkable for a weight gain of about 25 pounds over the last 5 years, extreme fatigue tiredness since 4 months to the limit that she was working every other day, lower limb weakness from going upstairs and walking, marked sweating for 1 year, and mild facial hirsutism. However, she denied any history of easy bruising, previous fracture, past history of hypertension, galactorrhea, change of hand or shoe size, or eye symptoms. Her past history, as I mentioned, family history was positive for type 2 diabetes, hypertension, dyslipidemia in her parents. There was no history of alcohol intake or smoking. This was the list of her medications. She was maintained in Dostonix 0.25 milligram twice per week for at least 2 months prior to a clinic visit. And she was also taking multiple medication for diabetes. So she was on insulin TG of 120 units daily, Gliclazide 120 milligram OD, metformin 500 BID, and Trulicity 1.5 milligram once a week. She was on candesartan and indapamide for hypertension, rosuvastatin for dyslipidemia. She was on escitalopram and bupropion for depression, and domperidone for gastroparesis. So what do you think your clinical impression at this stage? Would you think that this patient has pituitary macroprolactinoma? Is it a drug-induced hyperprolactinemia with non-functioning pituitary adenoma? Or it's a macroprolactinemia with non-functioning pituitary adenoma? Or you think that other functioning adenomas needs to be ruled out at this stage? Kindly share your thoughts. So we're having at least majority of the attendees, 43%, they think it's drug-induced hyperprolactinemia with non-functioning pituitary adenoma. And the other options are splitted. So we have between the other options, between the pituitary macroprolactinoma or macroprolactinemia with non-functioning adenoma, or ruling out other functioning adenomas. So looking into drug-induced hyperprolactinemia, we know that drugs are common cause of hyperprolactinemia, and it's very essential to differentiate it from other pathological causes, which avoids unnecessary investigations. That's why detailed history will help us to identify responsible drug, and withdrawing the drug will be really rewarding in such patients. Like in this study, which was relatively small study, it was a retrospective study of 32 subjects in patients who were taking medication expected to cause hyperprolactinemia. Their actually basal prolactin level was 132, plus minus 68 nanogram per ml. However, after holding the drug, prolactin level reduced to 16.9. And the majority of those patients, they were taking proton pump inhibitors in combination with prokinetics. 15% of them, they had multiple drug combinations. Antipsychotic medications were taken in 9% of the cases and OCBs in 3% of the cases. And overall, most of them, they had symptomatic presentation. Commonest presentation females was galactorrhea, followed by irregular cycles and breast heaviness. And in males, it was mainly erectile dysfunction. Asymptomatic presentation was present in 6% of subjects, and all subjects actually really improved after withdrawal of the offending medication. And looking at the pituitary, at the Endocrine Society guideline for evaluation of pituitary incidentuloma, like this patient, she presented mainly with headache and vertigo. MRI was done for another reason, and it showed an evidence of pituitary macroadenoma. So that's basically the definition of pituitary incidentuloma. So what does the guideline tell us during evaluation of such patient? They recommend that all patients with pituitary incidentuloma, including those without symptoms, undergo clinical and laboratory evaluations for hormone hypersecretion. And the evaluation for hypersecretion should include an assessment of prolactin, growth hormone, and ACTH hypersecretion, and screening for glucocorticoid excess due to possible corticotroph tumor may also be considered when this is suspected clinically. And that was based on the finding that in 13% of the 300 pituitary adenomas who were tested in autopsy studies, they were found to be stained positive for ACTH. However, there was no previous systematic screening of incidentulomas for subclinical glucocorticoid excess. And patients with adrenal incidentulomas, they may have Cushing's syndrome-associated morbidities. We know that in the adrenal incidentulomas studies. That's why we could apply the same thing to pituitary incidentulomas patients. And whenever they have such comorbidities, they could be considered for screening of subclinical Cushing's disease. Moving into physical examination. So this patient, she was not in distress. She was actually vitally stable. However, her BMI was 29 kilogram per meter square. Her general exam was remarkable for facial plethora, mild hirsutism, round face, acanthosis nigricans, skin tags, and dorsocervical and supraclavicular fat pads. Her neck exam was palpable, showed palpable goiter more at the left side. And her other systemic exam was unremarkable, apart from small whitish striae in the abdomen, and visual field was intact. There was no skin bruises, no weakness, or galactorrhea. So in summary, she's a 53-year-old female with background of diabetes, hypertension, sleep apnea, depression, postmenopausal, found incidental to have pituitary macroadenoma. Prolactin level was 399. Review of history was positive for weight gain, extreme fatigue, lower limb weakness, sweating, and mild facial hirsutism. Physical exam was remarkable for BMI of 29, facial plethora, hirsutism, round face, acanthosis nigricans, skin tags, dorsocervical, and supraclavicular fat pads. So our initial impression at this stage was pituitary macroadenoma, and we need to rule out Cushing's disease and the hyperprolactinemia likely due to medication versus dose effect. Less likely to be prolactinoma, however, needs to be evaluated of the effect of domperidone. So speaking about clinical features of Cushing's syndrome, we know that there are some signs that could help us to discriminate patients with Cushing's syndrome because they have good specificity for Cushing's syndrome. Among these, the most common are ease of bruising and facial plethora. However, there are some symptoms that could be seen in other cases, so they do not help much in discrimination of from other population. However, they could be seen in patients with Cushing's, and those include weight gain, obesity, insomnia, menstrual abnormalities, and signs include most commonly facial or supraclavicular fullness, obesity, and poor skin healing. Her prior investigation, which were done at primary health care, showed HbA1c of 9%, Prolactin level, as I mentioned, 399, and AM cortisol 423. 1 month later, her prolactin level was repeated by her GB and it improved to 1.5 after they started cabergoline. Previous pituitary MRI done in the primary healthcare center showed a 12 millimeter pituitary adenoma that was abutting cavernous sinus and causing deviation of the stalk to the left without pressure on the optic chiasma. So what do you think now? What's the preferred test of Cushing's disease in this patient? Is it 24-hour urinary free cortisol? Is it overnight 1 milligram DEXA suppression test? Is it late night salivary cortisol, or any of the above could be used? So we're having at least 29% of the candidates. They think 24-hour urinary free cortisol could be started with, and 34% they want to start with 1 milligram DEXA suppression. 27% of the candidates they think any of the above tests could be used, and 11% they think about late night salivary cortisol. So regarding the Endocrine Society guideline in the diagnosis of Cushing's syndrome, they actually, for initial testing of Cushing's syndrome, they recommend any of the following tests, and that should be based on the suitability for a given patient. So either urinary free cortisol, but it should be done in at least 2 measurements, late night salivary cortisol, again in 2 measurements, or 1 milligram overnight DEXA suppression test, or using the longer low dose DEXA suppression test, which is the 2 milligram per day for 48 hours. If we want to compare those tests, we could see that 24-hour urinary free cortisol is considered one acceptable first-line screening test. It has sensitivity of up to 98%, specificity of 92%. However, you need to educate the patient about the proper urine collection, and it is really not helpful in patients who have impaired renal function. And you need to instruct the patient not to drink excessive amounts of fluid and to avoid the use of a glucocorticoid preparation. However, it's limited also by the fact that it can be falsely low in patients who have mild Cushing syndrome. Moving to late night salivary cortisol, it seems to be the best choice for screening for Cushing syndrome. It is helpful in assessment of cyclic Cushing. It has sensitivity ranges from 83 to 100%, and specificity reaches up to 97%. However, it is limited in night workers, people with a quantity of saliva that is insufficient for analysis, or those with oral diseases. Overnight 1 milligram DEXA suppression test, again, it is accurate as first-line screening test, and it is helpful in patients who have mild hypercortisolism. Its sensitivity and specificity are threshold dependent. So when you use the threshold of less than 50, it has sensitivity of 100%. However, specificity reaches up to 97% only when you use the highest cutoff of 138 nanomole per liter. However, it has its own limitation. It's limited in patients who take oral estrogen, because we are measuring the total serum cortisol, and that could be affected by cortisol binding globulin that is increased by estrogen. Medication that impaired dexamethasone metabolism could affect the test result. And measuring, that's why in those patients, measuring dexamethasone level could help to identify potentially abnormal dexamethasone clearance. However, it's not performed routinely in a clinical practice worldwide. The last test is 2 milligram DEXA suppression test. Again, it's one of the first-line screening tests. It's helpful in mild hypercortisolism. It could reach sensitivity of 95% when you use the cutoff of 50 nanomole per liter, and at a lower cutoff, its sensitivity reaches maximum 90%. It has good specificity of 92 to 100%. It has the same problems of 1 milligram DEXA suppression, where you have abnormalities of cortisol binding globulin, or there is abnormal dexamethasone metabolism. And in a special population like pregnant ladies, the Endocrine Society, they recommend against the use of DEXA suppression tests and to use urinary free cortisol instead. In patients who have epilepsy, again, they recommend against the use of DEXA suppression tests because of the effect of anti-epileptic medication in the metabolism of dexamethasone, and the other tests like urinary-free cortisol or late-night salivary cortisol could be used. In patients with renal failure, they suggest to do the 1 milligram DEXA suppression test rather than urinary-free cortisol. In patients who have cyclic Cushing, they suggest to use urinary-free cortisol or midnight salivary cortisol rather than DEXA suppression test. And in patients with adrenal incidentuloma, it's recommended to do either 1 milligram DEXA suppression test or late night cortisol test rather than urinary-free cortisol because it could be false negative in those patients. So our plan at this stage was to hold cabergoline, hold domperidone, to do 1 milligram DEXA suppression test and 24-hour urinary-free cortisol 2 times, to do pituitary profile, including prolactin level, and to repeat pituitary MRI. You can see her investigations. She had basically normal CBC, normal creatinine and electrolytes, including normal potassium of 4.2. Her ALT was mildly raised of 70. Her A1C was uncontrolled with 9.3%, and she had LDL of 2.44. And to investigate for Cushing's disease, we did initially 1 milligram dexamethasone suppression test. Her cortisol did not suppress at 312. Her initial 24-hour urinary-free cortisol was still within the normal range. It was 592. And that was after she finished a course of fluconazole for genitourinary fungal infection. So we contributed the normal level to fluconazole at that time. So we asked her to repeat another test, and her repeated urinary-free cortisol was ranging between 1.05 to 1.18 upper limit of normal. However, the repeated dexamethasone suppression test showed unsuppressed cortisol. Her rest of pituitary profile showed high LH-FSH going with her postmenopausal state, normal TSH and free T4. The repeated prolactin level of cabergoline at 1 month was 5.3, and at 2 months was 59.1, and she had normal IGF-1. Her repeated pituitary MRI showed almost similar finding to the one reported previously in the primary health center, where we have a 12 millimeter pituitary adenoma abutting cavernous sinus and away from optic chiasma. And you could see the same here in the sagittal view of the MRI. So what's your interpretation of the above test? Do you think it's consistent with Cushing syndrome? Do you think there's some discrepancy in the above test? Or do you think it's not consistent with Cushing syndrome? Kindly share your votes. So 50% of the attendees, they think it's consistent with Cushing's, and 34% they think it's there's some discrepancy, and only 16% they think it's not consistent with Cushing's syndrome. So if you look at the algorithm to diagnose Cushing's syndrome, so once you suspect Cushing syndrome, you have to exclude number 1, exogenous glucocorticoid exposure, and then number 2, you have to perform one of the following tests, which we already discussed, which is either urinary-free cortisol, 1 milligram DEXA suppression, or late-night salivary cortisol, or the 2 milligram DEXA suppression test. And if there is any abnormal test, again, you have to exclude physiologic causes of hypercortisolism, and then you have to perform either 1 or 2 of the studies that were shown above. And in some population, some second-line tests, which we will discuss further, could be considered. If you have an abnormality, that's Cushing syndrome. If it's normal, then Cushing's is unlikely. If there is discrepancy, you could again do additional evaluation. So the Brazilian Society of Endocrinology, they suggest first-line test as the low-dose DEXA suppression test, or the longer low-dose DEXA suppression test, which is the 2 milligram per day for 48 hours, or the late-night salivary cortisol, or the urinary-free cortisol. And they put the cutoff limit for urinary-free cortisol to be at least more than 3 to 4 times upper limit of normal. In our patient, it was actually less than that. And they suggest second-line tests like late night serum cortisol in some population, or the CRH after low dose dextrosuppression test, or the human CRH test, or the desmopressin test. So because our patient, she did not achieve a urinary free cortisol of 3 times upper limit of normal range, we contributed that basically maybe to the effect of cabergoline that she took previously. So that's why we asked her to beat another 24-hour urinary free cortisol and to do the 48-hour dexamethasone suppression test to complement our studies. And we found that her 48-hour dexamethasone suppression test was not suppressed, and her urinary free cortisol was actually increasing. It reached 3 times upper limit of normal range. So which of the following now at this stage of evaluation of this patient will be the best next step? Will you send this patient for transphenodal surgery? Will you start medical therapy? Or you will send this patient to inferior vitreosa sinus sampling? Or you need still to do some further tests? So we're having splitted answers. I have 33% they want to start medical therapy, 28% they want to do further tests, 26% they want to send this patient for transphenodal surgery, and only 12% they want to send this patient for inferior vitreosa sinus sampling. So we know in the algorithm of diagnosing patients with Cushing syndrome, once you confirm the presence of Cushing syndrome, like in this patient, we're having repeatedly unsuppressed cortisol after dexamethasone, whether the 1 milligram or the 2 milligram, and we're having a high urinary free cortisol. So for us, that was confirmed Cushing syndrome. So our next step was to do the ACTH level. And actually, the recommendation, they usually recommend it to be done at least more than 1 sample. And if you have an ACTH level of less than 10 picogram per ml, that's ACTH independent. So you have to image the adrenal gland by either CT or MRI to rule out adenomas or carcinomas. However, if ACTH is more than 20, that's suggestive of ACTH dependent Cushing. So you need to do a pituitary MRI. And if you find a lesion more than 6 millimeters of diameter, you could send those patients for transphenodal surgery. However, if it is less than 6 millimeters of diameter, you have to do inferior vitreosa sinus sampling. And then depending on the result of inferior vitreosa sinus sampling, you could either image the other parts of the body looking for ectopic if the inferior vitreosa sinus sampling shows, for example, peripheral cause. If it shows central, you will send the patient for surgery. However, if it shows peripheral, then you need to do either anatomical imaging or functional imaging like X-ray scan or PET CT scan. However, if the ACTH is between 10 to 20, then you have to repeat the ACTH again, or you could consider CRH testing. So in our patient, when we did ACTH level, actually it was suppressed ACTH. So our next step was to image the adrenal gland, and we actually find a 2 centimeter lipid-rich adenoma in the right adrenal gland. And surprisingly, when we reviewed her previous CT scan, we found that she had a previous CT abdomen that was done to investigate for abdominal pain 3 years ago, and actually showed the same right adrenal adenoma. However, it was overlooked and it was not reported by the radiologist in the official CT scan report. So our final diagnosis was ACTH independent Cushing syndrome secondary to adrenal adenoma. So this patient was sent for right adrenalectomy, which she had. Her pathology was consistent with adrenal adenoma. There was no malignancy. Post-operatively, she was replaced with steroids. She was able to stop her insulin gliclazide for DM, and she was able to lose at least 5 kg in the first clinic visit around 1 month after surgery. She was at the first clinical visit, she was still complaining of fatigue, but that was attributed to steroid withdrawal syndrome. You can look at her post-operative cortisol level and ACTH. You find that her AM cortisol was very low after surgery. It was 39 nanomole per liter, and her follow-up ACTH during follow-up started to increase gradually till it normalized. So what do you think now at this stage? Should we follow up her cortisol level? Should we follow up CT scan adrenal gland, or follow the MRI pituitary, or follow up prolactin level?
Two minutes.
So we have 27% they think to do CT adrenal, and 44% they think follow-up of cortisol level. Can I have 5 minutes more, Dr. Raya, just to finish the review at least?
Go ahead.
Okay. So actually, what we elected to do in this patient is to follow up her prolactin level. Her story with prolactin did not finish. We know that she initially had a prolactin level of 399 that was on medication, and now the medication is held. So we wanted to see her prolactin level of the medication effect, and surprisingly, her prolactin level increased again to 267. So for us, that was really consistent with macroprolactinoma, and we started her on dopamine agonist. So we're having a patient who has two different endocrine tumors. She has ACTH-independent Cushing syndrome secondary to adrenal adenoma. In addition to that, she has pituitary macroprolactinoma. So just a quick review about Cushing's syndrome. It's really a serious and well-known medical condition that results from persistent exposure of the body to excessive glucocorticoids, which could be either endogenous or from most commonly exogenous sources. The average age of diagnosis is 41 years, and female to male ratio is about 3:1. Most commonly, Cushing's is caused by ACTH-dependent Cushing. So most commonly in 70% of the cases, it's because of pituitary disease, and in 10% could be due to ectopic ACTH syndrome. 20% of Cushing's is only caused by ACTH-independent Cushing, and majority of those patients, they have adrenal adenoma. If you look at the list of signs and symptoms of Cushing's syndrome, they're really non-specific symptoms and signs, apart from some specific symptoms that we mentioned, some of them already, which helps to discriminate those patients from other patients who have the common clinical comorbidities. So we have facial plethora, proximal muscle weakness, large stria, and spontaneous ecchymosis should be always looked for in patients who are suspected to have Cushing's syndrome, because these are really specific signs of Cushing's syndrome. Who should be tested for Cushing's? So Endocrine Society, they recommend to test patients for Cushing if they have unusual features for age, like hypertension, osteoporosis, if they have multiple and progressive features, particularly those which are more predictive of Cushing's, that the one we mentioned already, children with short stature and increasing weight, patients with adrenal incidentallomas compatible with adenoma. And they recommend against widespread testing of Cushing's in any other patient group. Again, the Brazilian Endocrine Society, they recommend to almost similar recommendation for testing of or screening of Cushing's syndrome, but they recommend to pay special attention to the specific symptoms which we already mentioned. Why we need to look for Cushing's? Because we know it is associated with significant mortality. So when they compare the mortality of patients with Cushing to the match control, it was twice as high in patients with Cushing in comparison with matched control. And in addition to that, they have also significant morbidity. So our aim is to lower the mortality and morbidity, and they usually have significant risk of venous thromboembolism, infections, MI, stroke, and fracture. That's why you need to test those patients and to detect them early in order to prevent those comorbidities. Unfortunately, most of those patients, they really spend a long time till they are diagnosed with Cushing syndrome. Like in this meta-analysis, it was found that the time to diagnose patients with Cushing syndrome was 34 months. And it was variable among the causes. So you need the so you see that the shortest time was in patients with ectopic Cushing, maybe because those patients, they have more florid aggressive disease. That's why they are diagnosed earlier than the other types of Cushing's syndrome. What's the best treatment for those patients? Is actually surgical. So whenever you find the tumor, whether it's in the adrenal gland, it is in the ectopic source, or in the pituitary, then resection is the best treatment option. Was there similar cases reported in the literature similar to our patient? I actually found this case report about simultaneous pituitary and adrenal adenoma in patients with non-ACTH dependent Cushing syndrome. So basically, she was a 37-year-old female. She presented with amenorrhea and weight gain. She was already on L-thyroxine for hypothyroidism. They saw that she had low TSH and low free T4, so they did a pituitary MRI, which showed 6 millimeter pituitary microadenoma. So, and then they suspected Cushing's based on her clinical symptoms and signs. And that was confirmed biochemically based on high urinary free cortisol and unsuppressed cortisol after dexamethasone. However, her ACTH was suppressed, similar to our patient. So they did the MRI of the adrenal and found 33 millimeter left adrenal adenoma. The patient underwent surgery for her adrenal adenoma. And they concluded that coexistence of adrenal adenoma and pituitary adenoma with Cushing's is a rare possibility, and due to diversity in the presentation of Cushing, an accurate clinical, physical, and endocrine examination is always recommended. Another close case to our patient, this was basically a patient who was diagnosed to have Cushing's disease, and that was based on the having unsuppressed cortisol after 1 milligram dexa, and however, it was mainly ACTH mediated. So ACTH was normal, and they found a 5 millimeter adenoma in the pituitary MRI. For some reason, they did also a MRI of the abdomen, and they found another adrenal adenoma of 1 centimeter in the left side. To confirm the source of the hypercortisolism, bilateral inferior pituitary sinus sampling was done, and it was consistent with central source lateralized to the right side, so she underwent transsphenoidal surgery. Her pathology was positive for ACTH, but it was not consistent with adenoma or hyperplasia. 3 months after her operation, her cortisol still was not suppressed with dexamethasone, so they did again bilateral inferior pituitary sinus sampling, which again lateralized to the right side. Pituitary MRI did not show adenoma, so they gave her gamma knife radiosurgery. In the 3rd year of gamma knife radiosurgery, she again had weight gain and uncontrolled glucose, and for the first time, after confirming that she has unsuppressed cortisol, she had suppressed ACTH level. And at that time, they did MRI of the abdomen, and they found 24 millimeter adenoma in the left adrenal gland. So she was diagnosed to have adrenal Cushing's, and she underwent left adrenalectomy. So they concluded that we know that in patients with Cushing disease, the presence of adrenocortical hyperplasia is a well-defined entity. It can be found in 70 to 80% of patients. However, autonomic transformation of adrenal gland due to long-standing ACTH hypersecretion could occur. Like this patient, she had non-functioning adenoma, and then it became functioning and showed ACTH and independence. So in conclusion, evaluation of hyperprolactinemia should take into account variable etiologies. Prolactin level could help in differential diagnosis of hyperprolactinemia, but this rule is not always absolute. And any patient with symptoms suggestive of Cushing should be evaluated for this possibility. Thorough evaluation should be undertaken. Biochemical testing should always be the leading in approach of such patients. Imaging studies could be misleading in such group patients, and the presence of both pituitary and adrenal adenoma is rare, but it could occur. My last take-home message is I would recommend accurate and careful endocrine evaluation as mandatory during the course of Cushing's syndrome evaluation to provide appropriate management and successful outcome. Thank you so much.
Thank you so much, Dr. Reem. Thank you so much for this interesting case. I just would like to remind the audience, please place your question in the Q&A section, and hopefully we will address them at the end. Our next talk is titled Nuclear Imaging in Endocrinology, and we are delighted to have Dr. Hidayat Ali Ansari with us. Dr. Hidayat is a consultant radiologist and chief of nuclear medicine at the Imaging Institute of Cleveland Clinic, Abu Dhabi. And he is the medical director of Cleveland Clinic Abu Dhabi Al Ain branch. His areas of specialist expertise include PET-CT, nuclear medicine, CT cholangiography, and MRI enterography. Dr. Hidayat kindly recorded his talk, but he is available with us in the Q&A, so please place your question. We can start the recording.
Hidayat Ansari. I'm the chair of nuclear medicine and consultant radiologist at Cleveland Clinic, Abu Dhabi. Today, I'm going to be talking about nuclear imaging in endocrinology. The objectives of my talk is to discuss the role of nuclear or metabolic imaging in benign and malignant conditions. I would like to list and review common isotopes utilized in endocrine imaging. I would like to identify the indications and applications for PET-CT scanning. I want to review some novel isotopes utilized in this process and understand the limitations and pitfalls in endocrine imaging. With that, I would like to give a quick background of metabolic imaging. Conventional anatomic imaging may be limited due to equivocal size of these lesions because they can be small. But the role of functional imaging has been increasing over the last few decades. It helps better localize and characterize these lesions. It provides functional status and tumor activity when present. It differentiates recurrence versus post-surgical changes. So what have we been using in the past and in the current state? Let's have a look at that. So because functional imaging provides diversity. In the past, the nuclear medicine has been, funny enough, called unclear medicine because it has not been precise enough with its anatomic information. But in the current state with hybrid imaging, we have the new clear medicine. In the past, we used planar imaging with no anatomical correlation. And as I said, with hybrid imaging, we have precise anatomical correlation. We have moved on from gamma SPECT to positron emission tomography, which has enhanced sensitivity and specificity. Previously, and even to date, we use some regular isotopes such as technetium for thyroid, technetium maybe for parathyroid imaging, iodine 123 for thyroid uptake scan, iodine 131 for thyroid therapy, indium 111 octreotide scanning, and I-123 and 131 MIBG scanning in cases such as for pheochromocytomas, for example. But today we are using F18 FDG as a routine isotope for PET-CT imaging, and in special cases such as neuroendocrine tumors, we do dotatate imaging and dopamine as well in some of the neuroendocrine tumors and medullary thyroid carcinoma, as I'm going to talk about that. To achieve this, what we need is radiochemistry kits, we need generator, we need the isotope, which can be produced from the generators and the cyclotrons, which is used for both regular nuclear medicine imaging under a gamma camera or under a PET-CT scanner. What have we been doing in terms of image acquisition? We've been doing anterior, posterior, planar imaging and tomographic image acquisition, and of late, hybrid SPECT-CT imaging. So if you see the image on the left, this is a very non-specific image with very poor sensitivity. And to date, this has been improved by three-dimensional tomographic correlation, and with PET-CT and fused images on the right, you can see the precise anatomic localization of functional status of these lesions. To understand what is pathology, we need to understand what normal physiology looks like. So whether it is a regular technetium scan or a PET scan, we as readers need to understand what is the physiological uptake of the isotope and what is the pathological uptake of the isotope. With that, I would like to go through some neuroendocrine abnormalities from head to toe. So let's start with pituitary adenomas. So pituitary adenomas are very uncommon, but they can be seen. FDG PET is not a routine scan which is used for diagnosing pituitary adenomas, but it has frequently picked up on FDG PET CTs, as you can see in this particular image, with the increased intensity in the suprasellar region, and this was confirmed to be a pituitary macroadenoma. And so can these pituitary glands be seen on dotatate scan on the left image below, whilst physiologically as well, pituitary gland can be seen on dotatate PET, In pathological cases, it is enlarged in size with intense increased uptake. Coming to thyroid imaging. Thyroid has been traditionally imaged with ultrasound and technetium-99 pertechnetate. And to add that, we have added SPECT-CT imaging. Let's take an example of this case with a large thyroid nodule in the left lobe of the thyroid gland. When you do a technetium thyroid scan, you can see that as a photopenic defect in the left lateral aspect of the thyroid gland with attenuation of the gland itself. But when you add in a SPECT-CT, it precisely localizes where exactly the thyroid nodule is and how it is distorting the thyroid gland anatomy and displacing the thyroid gland structures in the neck. And if there was any retrosternal extension, you can pick that up on this CT component. The thyroid nodules, needless to say, are extremely common, up to 7%, more common in females. And when you see a cold thyroid nodule, there is a tendency for up to 10% for these to be malignant. And that's when we work these nodules further. So looking at some of the examples of thyroid uptake scans. So what we try to do is look at the activity in the thyroid gland versus the background activity. And a normal ratio is in between 0.2 to 2%. As you can see, this particular one has 1.5%, and it is a normal thyroid uptake. But what about the case on the left bottom? The proportion visually quantifying this case, you would say there is a diffuse increase in the isotope uptake across the thyroid gland. And if you look at the quantification values, it's almost 5.3%. And this is a case of Graves' disease with diffuse increase uptake. What about this next case in which there is hardly any background uptake across the thyroid gland? It's hardly 0.1%. And this is a case of subacute thyroiditis. And in this case, on the right bottom, which shows multiple nodular foci of uptake with a dominant and an autonomous nodule on the top. So let's look at some examples of both negative and positive iodine-123 scans. This is a planar image, anterior and posterior. There is no uptake on the image to be suspicious for metastatic disease. But when you look into the PET-CT, in this case, it shows increased activity in multiple areas in the lungs in keeping with multiple pulmonary metastases. And you can see an example of one of those lesions in the bottom right of the screen. Another example of a negative iodine scan, you can see the thyroid image on the CT on the left. And the thyroid uptake scan shows no activity on the planar images. But if you look at the PET-CT scan, it shows intense uptake across the left glottis and the vocal cord, and this was a deposit in this region. An additional deposit in the left lateral aspect of the sternum. What about positive iodine scan and negative FDG scan? Here you have a case with multiple bone lesions, which you can see particularly in the bony pelvis and around the level of the urinary bladder. But when the same scan was done on FDG PET, it did not show any significant increase across the pelvic bones. And this both iodine scan and FDG scan should be taken to complement each other where necessary. How does the thyroid gland look on the PET-CT scan? If it has diffuse uptake, it's usually related to thyroiditis, and that can happen in about 5 to 10% of the cases. But when you have a focal uptake across the thyroid gland, this is considered abnormal until proven otherwise, and we recommend an FNA and biopsy to characterize this further, because usually almost 5% of these turn out to be malignant. What about PET-CT in thyroid carcinomas? If you have a differentiated cancer, it's usually positive on iodine-131 scan. But if you have a dedifferentiated cancer, that's where we use the F18 FDG scans. If you have a thyroglobulin level greater than 10 nanograms and you have a negative iodine-131 scan, that's when we prefer to use the FDG PET scan. It is useful at identifying recurrence and metastasis. It has a high prognostic value, and its sensitivity can be up to 72%, when the thyroglobulin levels are greater than 10, and 95% in cases of suspected recurrence or metastatic disease. It can also be positive in medullary thyroid carcinomas when the calcitonin levels are above 1,000 picograms per ml. In cases where you have poor results with FDG PET, recombinant TSH may be administered, and it increases its sensitivity, as you can see on the bottom image on the right. So let's look at what else is used in thyroid imaging. As I mentioned, we have a new isotope on the block called F-DOPA, and this is extremely useful at picking up medullary thyroid carcinomas, as you can see in the left lobe of the thyroid gland on the bottom fused image. What about parathyroid imaging? Again, traditionally, we have been using ultrasound and technetium, maybe with now advent of 4D CT being increasingly used. They all complement each other to an extent to identify the focal parathyroid adenomas. Technetium maybe itself has a sensitivity of 80% and specificity of 71%, but it can be false negatives in small adenomas. So we have this new isotope called fluorocholine, and we use this increasingly at Cleveland, and so hopefully we can supply this isotope to the other centers across the country, which we'll be producing soon. This has a sensitivity of almost 94%. It picks up on the biosynthesis of the cell membranes and phospholipids, and that way it identifies the parathyroid adenomas. Let's look at a few examples. In a traditional, maybe parathyroid imaging, the thyroid has some diffuser activity. Sometimes you see nothing else in the thyroid bed, and the thyroid activity washes out, and this is a normal parathyroid imaging. But on the case on the left below, you can see a focal area of tracer retention. On the nuclear medicine image alone, you can say it's around the left upper pole of the thyroid. But when we have SPECT imaging and fused hybrid imaging, it beautifully localizes the left upper pole, or rather superior pole parathyroid adenoma. Let's look at some other examples of, in this case, with double parathyroid adenoma. There is one in the inferior pole of the left and one in the superior pole of the right. And both of these are intensely avid on this technetium scan, and this was confirmed to be a dual parathyroid adenomas. One of the primary role of doing MIBI imaging is to identify ectopic parathyroid adenomas. Like in this case, you can see a focal area of uptake in the tracheoesophageal groove in the left anterolateral paraspinal location. And when you had a benefit of doing a 4D CT in this particular case, you can see a linear ovoid structure, which is enhancing in the left paraspinal space. In the I cannot point for some reason. It is anterior to the vertebra in the left lateral location adjacent to the esophagus, and this is sitting in the groove there, and this was confirmed as a ectopic parathyroid adenoma. Is there any role of parathyroid adenomas with FDG imaging? It is primarily not intended for that, but you do see a lot of incidentalomas, and which have been subsequently proven as parathyroid adenomas on FDG imaging. As I just mentioned, fluorocholine is the new kid on the block for imaging parathyroid adenomas. This is extremely sensitive and specific, as this identifies a small parathyroid adenoma in the left tracheoesophageal groove here. It has excellent detection and localization rates. It has a short acquisition time and lower radiation dose, because everything is done like in a one-stop shop, and we don't need to do a separate 4D CT and an ultrasound. If you, I suppose you will not get insurance approval if you don't do an ultrasound. So after an ultrasound, we can probably skip the other steps and go for this fluorocholine PET CT if you're expecting an ectopic or a subtle parathyroid adenoma. What about parathyroid carcinomas? These are uncommon. They usually have poor prognosis and delayed presentation, sometimes metastatic to lung, liver, and cervical lymph nodes. This was a case of a proven parathyroid carcinoma in relation to the left lower pole of the thyroid gland, and this was a case with skipping slides. This was a case of post parathyroidectomy for carcinoma with a lung nodule and had intense increased uptake. Coming now to pulmonary carcinoid imaging. CT is usually used for carcinoid diagnosis. They are round to ovoid shape. They can be speculated and irregular. In terms of nuclear imaging, we have been using octreotide in the past and now gallium PET CT for these. FDG PET CT has a very low grade FDG uptake, and their sensitivity is not good. But FDG uptake can vary depending upon the histological type and proliferation. Let's look at a few examples. Here you have a case of a lobulated left lung tumor, which was proved carcinoid of the lung. And this shows an octreotide scan in the left bottom image, which shows intense increased uptake. This was a case of intrabronchial carcinoid, but on an FDG scan, it does not show any uptake because it's not expected to show increased uptake, but it was thought to be a lung cancer at that stage, and they wanted to prove and exclude other lesions. And this was confirmed as not a lung cancer, but a carcinoid, but the uptake you're seeing in the lung is secondary inflammatory uptake. But this is the same case. And this is a case of a lung carcinoid, however, on DOTA scan. And this shows intense increased uptake and gallium dotatate avidity, which is expected to see in carcinoid tumors. And this is the endobronchial location of that tumor on that coronal CT chest. What about adrenal lesions? About 2 to 5% on CT, these adrenal lesions are incidentalomas, and 95% of these are benign. You see all kinds of lesions, fatty lesions, cystic lesions, adrenal hyperplasias, and adrenal adenomas. So CT and MRI are usually the first line of investigations which pick up these adenomas. But for functional value, they don't have any added diagnostic value. So PET CT is useful because it can assess the functional status of an adrenal uptake versus the liver uptake. Cortisol secreting adenomas have been shown to have increased SUV max of up to 6. Aldosterone secreting adenomas have been shown to have SUV max of up to 4. So you can ideally identify these, although these investigations need to be complemented with biochemical profile. In this particular case, you have bilateral tiny adenomas and increased uptake on both adrenal limbs. How do you see them? Visually, they have increased uptake, and you also can quantify them to see whether this is greater than 3.1. You can have falsely positive adenomas as well. This is a case of a non-functioning adenoma with no increased uptake, fatty density, and this was proven to be non-functioning adrenal adenoma. Another case on the left. They can be seen in up to 20% bilateral. And how do you diagnose this? Preferably with an MRI on a chemical shift artifact. Adrenal lesions can be also picked up incidentally, and in some cases, retrospectively correlated. In this case, it was ACTH-dependent Cushing syndrome with increased adrenal uptake. A new isotope called carbon-11 metomidate has been used to pick up these adenomas. We do not have this in production in UAE, and I'm not aware of any center doing this locally. And this has been shown to be useful for primary aldosteronism, where adrenal vein sampling has been limited or challenging. In adrenal carcinomas, PET CT can be extremely useful, A, because of its size, and secondly, because of its uptake. And up to 80% of these tumors can be functional with Cushing syndrome with or without virilization, and in 30% they can present with distant metastasis. The 5-year survival is low at 22%. Let's look at other adrenal lesions. In particular, pheochromocytoma. 80% of these are catecholamine secreting. They are usually large, around 4 to 5 centimeters at presentation. Anatomically, these can be picked up on both CT and MR. Some of them have cystic caliber, some of them have enhancing characteristics, and that usually the radiologists are in a good position to comment on the possible pathology of these lesions. But when we add in MIBG and PET-CT, it gives us additional functional information. And most malignant pheochromocytomas are positive on FDG PET, and most benign pheochromocytomas are positive on MIBG and octreotide scans. Let me show you a few examples. This is a case of a pheochromocytoma on the left, exophytic lesion. You can see it on the CT and you can suspect it on the CT, but it gives you functional information on this DOTA scan on the right with focal increase uptake. What about paragangliomas? Again, FDG PET-CT is extremely sensitive in picking up paragangliomas. And this is a case of a 48-year-old male uncontrolled hypertension, elevated catecholamines and metanephrines. You can see this lesion in the right suprarenal aspect with intense increased uptake on FDG in the middle image. On the right, same patient with the coronal image, and this was resected and proven to be a paraganglionoma. Moving on to dotatate imaging in neuroendocrine tumors, which is now becoming a large chunk of neuroendocrinology. And this is a case, let's go through some quick points on neuroendocrine tumors. This is a heterogeneous group from indolent to highly aggressive tumors. We can pick this up because of the somatostatin receptors present on the cell surface. We've been using gallium-68 for detecting these because these are extremely sensitive and specific compared to the previously used octreotide scan. They can be used for staging and restaging of tumors. It can be used for identifying metastatic disease, and is also used for radionuclide therapy, both pre and post, for follow-up purposes. In terms of utility in the tumor groups, as I said, it's used for neuroendocrine tumors, whether thyroid, bronchial, or gastrointestinal, and for gastroenteropancreatic tumor groups, including carcinoid, gastrinomas, glucagenomas, and lipomas. Let's look at a few examples. This is a case in which you may struggle to look at find where exactly is the pathology on this particular contrast scan on the left. But if you look at the dotatate scan, it shows that there's a focal area of increased avidity at the pancreatic tail next to the splenic bed, and this is the site of the hyper-enhancing tumor. You can see retrospectively on the contrast-enhanced CT scan. Same on the image below, you can see that at the level of the celiac axis, there is some nodularity, but when you look on the metabolic information, this is intensely avid and abnormal. This is an example of a patient with post-distal pancreatectomy and splenectomy for a neuroendocrine tumor, and the patient comes back with increasing catecholamine levels, and this was proven to be a caudate liver lobe metastatic deposit. So left is an image of an octreotide scan, and right is an image of a gallium PET-CT scan. This is a patient preoperative and postoperative on the right, and this just shows the utility of octreotide scan and gallium scans in the neuroendocrine tumors. I would like to slightly emphasize the information provided here about neuroendocrine tumors, saying that sometimes we have to use both FDG PET and gallium dotatate, both scans in the same patient, for reasons below. On the top, you have a gallium-68 PET scan, which does not show any significant increase uptake. But on the bottom, you have an FDG PET scan, which shows intense increase uptake. So this is because of tumor heterogeneity and differentiated disease. And this is very extremely useful because they complement the information they provide by both FDG and gallium scan. They help us guide biopsy for tissue diagnosis. And in this case, the Koenig's, so the additional value of nuclear endocrine imaging comes when we talk about theranostic agents. What are these? This is basically integration of both diagnostic and therapeutic functions, and this is a theranostic pair. What we do is we do gallium dotatate scan, or you can do a gallium dotatalk for somatostatin receptor 5, or even gallium dotanok. These are the tracers available in the market. But the idea behind doing this is to see which receptors have increased avidity and treat accordingly, because we can treat the patients with lutetium-177 dotatate. And this is the similar DOTA, but it is now connected to lutetium, which is a beta emitter, which goes in to the tumor level, sits there, starts emitting beta radiation, locally kills the tumor in the metastatic deposits, and thereby getting an effective therapeutic response. Yttrium has also been used, and it has its own efficacy and toxicity issues. So these are usually done around 4 cycles, 8 weeks apart. So this is a case of a 54-year-old who has been treated with PRRT, which is peptide receptor radionuclide therapy, which is lutetium dotatate. And post-therapy, you're trying to see, is there any residual activity? And this shows photopenic abnormalities and no residual increase uptake and therapy response. Let's look at a few examples. This is a 66-year-old small bowel carcinoid pre-surgery. You can see that there is a large lesion in the level of the terminal ileum, and subsequently the patient had surgery, and a follow-up scan showed multiple metastatic deposits. You would be probably struggling to see where exactly the lesion is, although you can see that there are 2 liver lesions. If you want to look into the mesentery and the abdomen, you might have to struggle to see, is there something in the next to the liver or next to the left paracolic gut? But if you do the same thing with the metabolic imaging, you can see extensive multifocal metastatic deposits in the entire abdomen and pelvis. And that's the added value of doing nuclear endocrine imaging to identify the extent of metabolically active metastatic disease. This is another case, a 62-year-old with abdominal pain, which was not detected for whatever reason. And here you see a dotatate scan shows a focal area of increased uptake. Now, this patient was confirmed to have Zollinger-Ellison syndrome, and this was a focal gastrinoma. Diagnosis can be often delayed. Patients present with hypergastronemia, diarrhea, and gastritis. This can be a feature of underlying MEN syndrome. This patient, these usually are seen in the region of duodenum and a triangle, and they are FDG PET-CT negative, and that's where the value of dotatate PET-CT comes into play. There's another case with insulin-dependent hypoglycemia. It can be seen in patients with the MEN syndrome. They're usually small, lesser than 2 centimeters. They are hypervascular, they may be calcified, and again, on FDG PET-CT, they are negative, unless they are of high grade or poorly differentiated. So we use gallium dotatate for these indications again. They have a sensitivity of greater than 90%. In almost 80% of the insulinomas, there is somatostatin 2 receptors, and that's why we use gallium dotatate. So this was an example of a MRI negative scan. There's no restricted diffusion or abnormality on the diffusion imaging. And when it did the dotatate scan, it showed a focal area of uptake adjacent to the uncinate process. This case was lost to follow-up, and we recommended endoscopic ultrasound and a biopsy. So as I briefly touched on this before, F18 DOPA is being produced locally, and we are using this increasingly for neuroendocrine indications and for medullary carcinoma of the thyroid. This is a patient with DOPA positive paraganglionoma in the neck. It is used for pheochromocytomas as well, and for midgut neuroendocrine tumors, lung and pancreatic tumors. Let's see what else I have today. This is a case of MEN syndrome. You can see that there is a parathyroid lesion on the left. In the middle of the screen, you can see a pituitary macroadenoma, and on the right, you see a pancreatic tail lesion. And this was one of the benign incidental pickup. And this was a patient with fibrous dysplasia. You can see what they call cherubism, or multiple deformities of the facial bones, and increased uptake. And this was a patient with McCune-Albright syndrome. These were my references, and with that, I would like to stop, and I hope I have been able to impress upon the advantages of doing nuclear endocrine imaging. Thank you. I'm open for any questions.
Thank you so much, Dr. Ansari, for the excellent review. Now I invite all the speakers for the Q&A session. So to start with the first question for Dr. Asma. So since there was an association between diabetes and the increased risk of cancer, what about intervention that reduce weight and leads to DM remission, bariatric surgery? Are there any study that follow these patients, compare it with the patient who don't have surgery? Does it ameliorate this risk or not? I mean, the risk of cancer.
Thank you, Dr. Raya. I wish if I knew that you will ask this question. Actually, I went through a study published in Ottawa Obesity Surgery Center, and it was published, I think, in 2007 in New England Journal of Medicine. And they were looking at the mortality post-bariatric surgery. And they looked at the different variables and different causes of mortality, like diabetes, cardiovascular, and cancer. And separately, without diabetes with cancer, they found that the risk of cancer decreased significantly, almost 1/3 comparing to the control patient in that cohort. They included around 10,000 patients post-bariatric surgery. So that's showing that the bariatric surgery or weight loss has really decreased the risk of malignancies in obese patients.
Excellent. Next question to Dr. Reem. Can you just unmute yourself as well? Can you just comment if you request salivary cortisol to your patient? What instruction do you give them? Just a general, I think, general question.
So if you want to do the salivary cortisol, it has to be done between 11 to 12 at night. They have to take the swabs of their saliva at least 2 times. And they have to avoid certain things like smoking, for example, and at least it has to be done 30 minutes before any meal. And if the patient took any meal, it has to be done 2 hours at least after the meal. And the sample has to be delivered next day to the lab.
Amazing. Dr. Hidayat. So I think you answered some of the question in Q&A. So I just, one of the question was whether there are other cancers that fluorochlorine can be used in. Another question, are there any, for example, thyroid nodule or lymph node in the neck? Can it lead to false positive in this scan?
Sure. So thyroid focal uptake can be false positive, but usually up to in between 3 and 6% of the cases have focal malignancies, and we see this as incidentalomas when we do PET-CT for other cancers or vasculitis cases. We pick up focal thyroid nodules, and we recommend endocrine referral so that these are FNA'd and biopsied and histologically proven either cancer or vice versa. And we found that there is a significant increase in cancer, basically because of the whether it is in the region where we live in and the female population, and we find quite a lot of focal incidental thyroid malignancies, and we have a low threshold for picking up this and highlighting these. And in terms of lymph nodes, we do see lymph nodes being positive from time to time, but a reactive lymph node, a cold and cough, may also cause some increased activity in the lymph nodes. I'm not so much worried about bilateral small volume lymph nodes as I'm worried about a focal thyroid nodule.
Excellent. Dr. Asma, one of the questions is regarding the one of the slides showed overall survival rate in cancer patient, diabetic versus non-diabetic, and those who are diabetic have a worse prognosis. So this was related to diabetes and its comorbidities, or it was cancer specific, cancer related mortality?
Most of these studies, they were adjusting to the confounding factors, and it's mainly for cancer specific death, not due to the other comorbidities.
Dr. Reem, I'm not sure if this is a question. So if the prolactin, the rapidity of a prolactin normalization after starting cabergoline, can this help in differentiating whether it is a prolactinoma or non-functioning adenoma due to stack compression or stack effect? Can it help?
I don't think there were studies looking into this. I didn't come across any studies which looked at the onset of normalization of cabergoline after the normalization of prolactin after starting cabergoline, because we know that cabergoline will normalize prolactin in all the causes of hyperprolactinemia. Now, to which level? It depends, of course, how high is the prolactin level and how large is the adenoma. If you're having a very large adenoma, of course, you will not expect it to normalize so quickly. But we see commonly that patients with micro prolactinomas, for example, even sometimes with the small doses of cabergoline, they're very responsive. And even that is seen even clinically. We see very commonly that some patients, they could get pregnant very quickly after starting cabergoline. But whether that will differentiate in the cause, I don't think so. As I mentioned, mainly the history of the patient, the level of prolactin, which will help us mainly to differentiate between the etiologies of hyperprolactinemia.
Amazing. Dr. Hidayat, there is a question regarding primary hyperaldosteronism and the presence of sorry, I just missed the question. So
I was typing an answer to that. So
okay.
It is not recommended to do FDG PET to characterize adrenal adenomas. I think adrenal vein sampling, although invasive, is more sensitive and specific, whilst an FDG PET would give you some activity numbers and quantification. It is not specific. You can have increased activity in adrenal hyperplasia, adrenal adenomas, and if you have a contralateral adrenalectomy, the left adrenal might be slightly overfunctioning, and therefore it is poorly specific, and that is not a recommendation.
Amazing. Thank you. Thank you for answering that. Dr. Asma, I think 2 questions. So then we will give everyone 2 more questions together. There is a question for you, whether there is, do you recommend holding SLG2 inhibitor in diabetic oncology patient? This is the first question.
Yes, because these medications increase risk of dehydration. Those patients is already due to their advanced, if they're having advanced condition, or due to the side effects of the chemotherapy, they would be at a risk of dehydration. And due to also the side effects of the medication that might put them at a risk of euglycemic TKA. So my recommendation is to stop really the SGLT2 inhibitor in patients who's on active chemotherapy.
Yes. So you mean inactive who have side effects of vomiting, poor oral intake, nausea, and all of this.
Yes.
So while stable patient, outpatient on other targeted therapy, no side effects, maybe can
if the patients on other targeted therapy, the risk would be less when they're not having a dehydration. but you never know about the euglycemic decay, when it would happen.
Exactly. Another question for you also, how much NAFLD is related to cancers?
NAFLD, you mean?
Yeah, NAFLD, yeah.
But there are many studies have been done in this regard, and actually it is very well known that it would be linked to a cancer.
Amazing. Dr. Arim, thank you for your outstanding presentation. Which type of glucocorticoid do not interfere with the urinary free cortisol and DST results? I mean, a patient can be on without need to stop them before the two tests.
So mainly dexamethasone is the one which does not affect the measurement of cortisol assays in general, but other forms of glucocorticoids, they all interfere with the measurement of the cortisol assays.
Excellent. Dr. Hidayat, do you have any specific instruction for patients who will go for example, for gallium dittate or somatostatin receptor imaging? What instruction do you give them regarding stopping their somatostatin analog?
Yeah.
If it is long-acting or short-acting?
If it is long-acting, we recommend 1 month pause, or preferably just before their next cycle. If it is short-acting, no need to stop any treatment. This is for the dotatate. For FDG, it's a completely different cup of tea. So therefore, we do not have, we are more concerned about their sugar intake and diabetes levels, because it works on the hexokinase pathway through the Krebs cycle. And therefore, we want to make sure that their blood sugar is normoglycemic.
Amazing. Any specific safety instruction? For example, they can use the public toilets and so on.
Right. Like any nuclear medicine study, they come with a small dose of radiation, which kind of decays within a couple of hours. So preferably avoid distance from young children and elderly people and pregnant patients if they have someone in the family. It's just a kind of a safety thing. If you look at the radiation quantification, it is hardly any different from a flight to New York or staying in a area with high seismic radiation or anything like that. So, but there's just a safety precaution. Yes, we ask them to try and maintain distance for at least 24 hours from vulnerable groups.
Excellent. Is FDUBA available in your center?
Yes, it is.
Amazing. Excellent.
No,
Thank you so much.
FDOPA, yeah. I'm going to have it in 2 months' time. Dotatate is available, yes.
Yeah, amazing. Thank you so much for all the speakers. Thank you for sharing with us the Q&A sessions. I think there are some other few questions. If you kindly answer them on the Q&A section, I would be grateful for all of you. Thank you so much, and hope we see you again in future meetings.
Thank you for the invite. It was very well organized.
Thank
Bye-bye.
you.
Thank you for the invitation. Thank you.
So now we will move to the last session, which will be about Gliclazide MR, effectiveness and safety in a real-world setting. And this session is sponsored by Servier. Our speaker is Dr. Antoine Erquier, who is a consultant endocrinologist at Imperial College London Diabetes Center, Abu Dhabi. And he's a former assistant professor of medicine in Tulane University School of Medicine in New Orleans, USA. Thank you for sharing, for being with us, Dr. Antoine, and you can share your slides.
Thank you. Thank you so much, Dr. Raya. Thank you for having me this evening, be with you and with good colleagues. I'm going to share my screen now. Okay, here we go. So I had the opportunity to be with you this evening, and going to be talking just about for maybe 15 minutes or so, just to get the message through. The topic of tonight is the Gliclazide MR, Diamicron. We're going to talk about the effectiveness safety in the real-world settings. So why real-world data? So what is really the difference between real-world data and the randomized controlled trial? So really, the real-world data can really have so much of added value because the controlled study, they have some constraints and conventional randomized clinical trials to evaluate what's really happening in normal clinical practice. So the question is, in randomized controlled trials, is really, can it work? But in real-world data, does it really work? First, we're going to step in the effectiveness in the real-world study of Gliclazide MR versus sitagliptin. This study was really aimed to compare the effectiveness and safety of Gliclazide modified release, the MR, to sitagliptin as a second-line type 2 diabetes mellitus treatment in a real-world patient population. So the primary outcome is to see the time to HbA1c level of less than 7%, whereas the secondary outcomes to see the time to HbA1c level of 6.5% and time to HbA1c of more than 1% reduction from baseline. The treatment duration is measured by both durability and persistence. I'm going to highlight on those in the next few slides. And the final point is the hypoglycemia events. So the study designed in a way that we have a baseline period where the main inclusion criteria is diabetic type 2, 18 years of age or older, first line with metformin, HbA1c more than 7% in the 6 months before index date, 12 months of historical data prior to index date. Then the main exclusion criteria is type 1 or other specific diabetes like gestational, neonatal, or secondary diabetes. And they were really used for a period of 9 years. So from 2010 until end of October of 2019. These are the baseline characteristics. As you can see, the group of the Gliclazide MR versus the sitagliptin, they're very much similar in terms of gender or in terms of HbA1c baseline of 8.5% or so. Then they were on other medication they were on, like anticoagulant therapy, antihypertensive therapy, antiplatelet therapy, and so on. So the primary outcome, as we mentioned, that the time to achieve HbA1c of less than 7%. As you can see in the curves, that the rapid separation of curves is in favor of Gliclazide MR HbA1c control starting at approximately 3 months. So this is the quarter of the year, it's about 3 months here, and 35% more likely to reach targets of HbA1c of less than 7% with Gliclazide MR versus sitagliptin. The secondary outcome, time to achieve HbA1c of less than 6.5, rapid separation of curves, you can see in here, in favor of Gliclazide MR, with about 51% more likely to reach targets of HbA1c of less than 6.5% with Gliclazide MR versus sitagliptin. So there was a similar durability and persistence. As you can see, with time, there was really a kind of superposed curves here. And durability means is index treatment duration until switch or add-on of a new antidiabetic drug or a stop. Whereas a persistence corresponds to the duration of index drug first episode, ignoring a potential add-on of a new antidiabetic drug. When hypoglycemia events is really assessed, there was a low or no significant difference. You can see the rate per 1,000 patients here, and the Gliclazide group was a 4.7 versus sitagliptin of 2.6, which was amazingly a good result as when we think of sulfonylurea when we talk about hypoglycemia. So it's about 4.7 hypoglycemic events per 1,000 patients here for Gliclazide MR. So in summary, is a well-designed real-world studies complement the RCTs. Extensive experience in using sulfonylurea, more than 60 years. Remember, the Gliclazide has been in the market for so long, and the risk and benefits well understood. The Gliclazide MR is a more effective glucose-lowering drug than sitagliptin, with similar rates of hypoglycemia, durability, and persistent to treatment. Now we'll move to the effectiveness, from effectiveness to the safety. There was a sub-analysis from the DIA Ramadan study. The objective of this sub-analysis study, this was a Dear Ramadan study, a real-world, observational, non-comparative, international study has shown that type 2 diabetes patients receiving Gliclazide MR during the Ramadan fast maintained glycemic control with no severe hypoglycemic events reported. All patients were treated with Gliclazide MR 60 milligram oral tablets, either alone or with other antibiotic treatment, except insulin, for at least 90 days prior to study start. The aim of this sub-analysis is to examine whether the positive results observed in the Dear Ramadan study are relevant to GCC region. This was about 1,214 type 2 diabetic adults in 9 countries, 64 sites and investigators. These 3 regions are culturally and geographically different, with different nutritional habits, but they represent some diverse cultural and nutritional habits of Muslim worldwide. So if you look at the left-hand side, you can see the study in the Middle East and included Egypt, Kuwait, Saudi Arabia, and the UAE is about 29%. 24% were in some Southeast Asia, Indonesia, and Malaysia, and 46% in Indian subcontinent. So the inclusion criteria were a type 2 diabetic patient, age 18 or older, with controlled or suboptimal controlled HbA1c, treated with a breakable glycoside 6 milligram tablet for at least, as we said earlier, 90 days before the start of the study, with experience in self-monitoring blood glucose and willing to fast during Ramadan, did not require insulin. The key exclusion criteria: insulin therapy, HbA1c more than 9%, severe liver or renal failure, contraindication to gliclazide, and pregnancy or breastfeeding, or previous experience of severe or repeated hypoglycemia event without triggering factors. So these people were excluded. So the patient already treated for gliclazide 60 milligram for at least 90 days before the start of the study. And this is visit number 0. This is the inclusion visit. And they were followed for pre-Ramadan period about 6 to 8 weeks, during Ramadan for about 4.5 weeks, and then post-Ramadan for 4 to 6 weeks, and then they had received the first visit. So the participant continued their usual type 2 diabetic treatment according to the usual practice. During Ramadan, physician advised their patient to take their Gliclazide MR at iftar time. The characteristics, as you can see on the right-hand side in red, the KSAUAE Kuwait group, they were higher HbA1c compared to the global group, and the higher BMI were observed in the GCC countries. Then more or so, there were higher mean dose of Gliclazide MR 60 in the GCC countries. So the mean dose was about 98.8 versus in the global was 74. So about 50% or so of the patient were on 120 milligram. So they required to have 2 tablets. The baseline characteristics, as you can see, I'm going to highlight the most important point is the IDF DAR. This is the International Diabetes Foundation with diabetes and Ramadan risk categories, because they have like 3 categories: very high risk, or category 3, which is moderate low. During the study, the 52% of patients in GCC countries were under very high to high IDF DAR risk category. So patients with at least 1 symptomatic hypoglycemia or confirmed hypoglycemia, symptomatic or not, or severe hypoglycemia. As you can see during this study, that in the GCC group, they had the symptomatic hypoglycemia was relatively low, and confirmed hypoglycemia is only 1, and severe hypoglycemia 0 compared to the global group. So really, as overall, there was really not much of a difference in terms of hypoglycemia. But there was an improvement in HbA1c were observed in the GCC countries. The HbA1c was a little bit lower, but from 7.9 to 7.6, whereas the weight, there was some kind of a little bit of a weight loss of 1 kilograms. So to make it simple and to get to the summary of the results in GCC countries, the symptomatic hypoglycemia about 4.3%, the confirmed hypoglycemia 0.6%, and severe hypoglycemia 0%. There was a reasonable HbA1c reduction of 0.3, and the weight reduction is about 0.7 kilograms. The conclusion of this sub-analysis study that patients taking Gliclazide MR 60 milligram in GCC countries had low rate of symptomatic hypoglycemia, no severe hypoglycemia, while maintaining good glycemic control and body weight. What about the cardiovascular safety of Gliclazide MR? And the Gliclazide associated with a lower risk of all-cause cardiovascular-related mortality. So all-cause mortality, if you compare Gliclazide to all other sulfonylurea, used from the older one, primary one, to the medium one, to the latest one. So if you can see, compare Gliclazide compared to others, they were all in favor of the Gliclazide, compared to the others. So all-cause mortality was really in favor of Gliclazide. When it comes to the cardiovascular-related mortality, again, one more time, Gliclazide compared to the other classical sulfonylurea was at advantage. So Gliclazide was really in favor of the less cardiovascular-related mortality. So this is just to show you that even though sulfonylurea, we're all concerned about the hypoglycemia and the severity of hypoglycemia that can be caused by sulfonylurea, that the Gliclazide MR was able to show you that hypoglycemia and severe hypoglycemia were, not that much increased as we classically and traditionally we would believe. And so use of Gliclazide MR, whether in the regular days or in the Ramadan time, should not be an issue. Now, obviously, you may not really start the Gliclazide in the first day of the fasting in the Ramadan month, because even according to the study, we had about 90 days run-in period before the fasting month of Ramadan. And I think I just came to my last slide. And thank you very much again for giving me the opportunity to be with you this evening in this great, well-organized meeting. Thank you so much.
Thank you so much, Dr. Antoni. Thank you for so much. I think we don't have a question. I just have one. In the efficacy study, did they study the time they need a third agent to achieve target glycemic control? I mean, was it the need for a third agent? Was it shorter in Gliclazide group or in sitagliptin?
Yes, in the study, they were in the efficacy where they're comparing this to sitagliptin. So according to this, they were not really using further other drugs in order to reach that. Otherwise, will be they cannot really tell the efficacy of the molecule itself per se compared to the sitagliptin if you have more other agents. So in this particular study was really comparing the Gliclazide to sitagliptin, alone. So there were not really interference of other more oral agents at the time. Obviously, no incident.
Excellent. We'll see. I encourage the attendees, if anyone have any question, please type in Q&A section. I think we don't have any more. Thank you so much, Dr. Antoine. Thank you so much.
Thank you, Dr. Raya. Thank you for having me. Thank you.
Welcome. Anytime.
Bye-bye.
So we reach the end of our session for today. Thanks for all the attendees. Just would like to inform you about the CME for this session today. It will be hopefully available 6 weeks after the webinar, and it will the certificate will be emailed to you through your registered email. So anyone who already logged in the webinar today, already they are registered, and you will receive it in your registered email. Also, I just would like to highlight that all these sessions are recorded and available in the website of the Emirates Diabetes Endocrine Society Institute. It has an educational part, and these webinars and all previous scientific meetings or sessions are available for your view at any time. Also, you could view them in the YouTube channel of the society. The other thing to announce is regarding our fourth meeting of Young Leader Forum that will be about men's health, and it will be held on the 16th of November, same time, 7:30. Also, again, we would like to thank Servier for their unrestricted support to this activity. Thank you so much for being with us all this time, and hoping to see you or to meet you again in the future meeting. Thanks a lot.